I thank the organizers for inviting me, particularly Serge. And thank you all for staying till the last session. And one of the nice things about being a penultimate speaker is that whatever you want to say, a lot of it has been covered and the background has been laid. So my task is somewhat simpler, and I will take a very simple perspective, and that is a transplanter's perspective of what to do with this mutational data. Really, that's the title of my talk, Influence of Mutational Status on Timing, Outcome, and Post-Transplant Management. Essentially, really, it is saying, as a transplanter, what do I take from this data, this new technology that is coming along? And so here is what I'm going to talk about. So I'm going to talk about the mutational status and timing of the transplant. And Dr. Vinton has laid a nice groundwork, so I will go over the studies in which there is an overlap. And really, as a transplanter, for me, the importance of these is to identify patients who have poor outcome and take them to transplant. And that's the sense I will take. But before I do that, I really also want to talk about what are our current outcomes with transplant. And so I briefly talk about that. Does it help in help me define that outcome of transplant? And there is one study which I'll show some data on. And finally, a patient who has undergone transplant, can we use some of these technologies to improve the outcome? So that's my remit, and here it goes. Here is my conclusion. So those of you who want to know what's going to be the bottom line, the bottom line is mutational status does identify certain patients, as you heard from previous speakers, particularly triple negatives and ASXL1 positive patients do have a higher risk. Patients who are CALR positive do have a better outcome after transplant. And finally, with highly sensitive PCR JAK2 assay, we can detect relapse after transplant early, which allows us to give them donor lymphocyte or immunomodulation. And this is quite interesting. So here is the decision-making process that I go through when a surgeon sends me a patient in the clinic. And the question really is when to do a transplant. So there are a lot of things that go into it, and you talk about what your patient thinks. Patient views are very important. Naturally, age and comorbidity is going to be quite important. Particularly, older patients have diseases and comorbidities and may not necessarily be suitable. Or at the other extreme, some older patients are very healthy, and they jog 2 miles, which I don't do. So again, we need to make a distinction there. What are the alternatives? And we heard a lot of alternatives. So again, this is a moving target as we were talking outside. Transplant outcomes have improved, and I'll show you the data. But so have other therapies, and we have to take it in consideration. Morbidity of transplant is sometimes forgotten when we talk about data on transplant, because all you talk about is survival. But you can have patients who have severe graft-versus-host disease, thankfully, these numbers are getting smaller, but there are occasional patients who are going to have a lot more morbidity than they had before transplant, particularly from a disease like myelofibrosis. But I think the two most important things in making this decision is what is the outcome of transplant, what is the mortality due to transplant, and what is the prognosis if they didn't have transplant. And I think if you take all that into consideration, the benefit of transplant in getting you long-term disease-free survival needs to be weighed against the risk of treatment-related morbidity and mortality. And that, in a sense, is what we all do in the clinic. And I'll spend some time on talking some of these factors. You saw this earlier. So how do we define patients for transplant? Who is a transplant candidate? And this, I think, is a nice tool This also includes cytogenetics, and we are fortunate that we do usually have this data when patients come to us. But these are, your standard risk factors that you look at, and based on that, you can divide them into two groups: intermediate, 2, and high risk. And if the survival is 16 months and 35 months, I suppose these patients certainly can benefit from transplant, even though it entails risk. And this was shown in this retrospective study by Dr. Kroger. And what he showed was in intermediate 2 and high-risk disease, you can show this nice separation in the outcomes between transplant cohort and non-transplant cohort. But they didn't see the same in low risk or intermediate 1 risk. The real nice thing, so here then are the transplant studies large enough of large enough number of patients that have been published to date. And in this one particular slide, this really tells you the story of transplant in patients with myelofibrosis. So this was one of the first studies. This was in median age of these patients was 42. This was in early 90s, and patients were treated at that time. And the question really we had was, in this fibrous marrow, can we get some patients to engraft? And needless to say, yes, we could, and there were some long-term survivors. The non-relapse mortality here was 27, but remember, the median age was 42. And if you take age older, the older patient older than 60, the non-relapse mortality, and so there were very few survivors. So really, it was then felt that this is something that is applicable to younger and fitter patients. As time passes, there are some other similar studies, and here is a study from Fred Hutch, which they have used myeloablative conditioning, and they come with some nice results, 57% with a median follow-up of 6 years. But probably the two studies that I want to talk about are this and this. Compared to the first study where non-relapse mortality was 27% with a median age of 42, in both these studies, the median age was 55. These are more current patients who you really want to take them to transplant, and non-relapse mortality was 16%. And same thing with this study, median age is now 58. So you are getting your average patient, it's with this disease, and in a non-relapse mortality, this is at 3 years, just 13%. So these results are certainly improving, and so it is in this light that we need to make decision about transplant today. So here is our own study, the last one that I referred to, and at a median follow-up of 5 years, in these 46 patients, 3-year survival is close to 70%. Mind you, these patients, almost all of them had intermediate 2 or high-risk disease. There was only one patient with intermediate 1-risk disease. So and the median age here was 58. Here is the event-free survival, that is 48%. And these numbers were obtained because the non-relapse mortality in this particular study was quite low at 13%, and relapse rate was about 39%. One of the nice things about patients who relapse after transplant is that immunomodulation is quite effective, and I'll show you some data. So many of these patients can be salvaged. And even many of these patients we have transplanted second time, and they have done well. So really, the survival is a lot better than the event-free survival because of the salvage therapy. So in this particular study, we looked at univariate and multivariate analysis, and here is the summary of what we found in multivariate model. So age, as has been in many of these studies, is an important prognostic factor. However, DIPSS plus category was highly significant with a P of 0.001, the hazard ratio of 5.9. And here it translates graphically. So patients with intermediate 2 disease did quite well, whereas those with high-risk disease on DIPSS criteria didn't do as well. So wouldn't it be nice if you could get them to transplant at this point or earlier, if you think that they have higher risk disease? And these results were due to the fact that patients with intermediate 2 risk disease had very low non-relapse mortality. This is just one patient here. So this is less than 5% treatment-related mortality, whereas higher-risk patients, DIPSS plus higher-risk patients had higher mortality, and of course had higher relapse rate as well. So the point I want to make here is patient earlier in the natural history of disease do have better outcome, as we see, and it's kind of intuitive, and we see it with many other diseases as well. And this is not just us. This is not a novel finding. These are data from Seattle, and they published the data based on DIPSS here. And as you can see, patients with early risk disease do better. So can we identify a subgroup of patients with poor outcome among those with early disease? And can mutation testing help? This is how I look at mutation testing. And so this was again shown that about 60% of the patients have JAK2, 30% have MPL, have CALR mutation, and a small number have MPL mutation, and about 5 to 10% have this triple negative. And it is this triple negative patients, and you saw this earlier as well, have a very have inferior survival of 3.2 years. So one could argue that if they have this inferior survival and if they have other problems due to the disease, certainly they are appropriate transplant candidates. This was another study saying the same thing. And this slide, again, Dr. Vinton showed, and what I want to point out here is that ASXL2 accounts for about 20% of patients. And this has inferior survival. So when you do univariate analysis, each of these mutations come out as indicating inferior survival. However, when you do a multivariate analysis, when you take into account the other cytogenetics and things that are considered in DIPSS plus, only ASXL1 stands out. So again, I would submit that these patients, if they have poor outcome, one needs to take that into account. Again, obviously, patient needs to have other features of disease and other issues. This was again mentioned earlier. More mutations you have, inferior the survival. And again, in appropriate context, that helps us as well. So to finish my part of first part of my talk, and this data was summarized in this particular paper, which is a consensus opinion. So transplant should be considered in patients with intermediate to and high-risk disease. And one could add some of these other factors, clinical factors, that do indicate high risk and need for transplant. And some of this possibly could be added to this list as well. That's my conclusion. So the next question is it possible to predict transplant outcome with mutation status? And this study, again, was shown earlier. And this is a patients who underwent transplant. And what you see nicely over here is those with CALR mutation did better after transplant compared to these other groups. And then certainly, this tells me that these patients are going to do better. So if they have an indication for transplant, one should certainly consider it. What interests me more is the reason is the difference in non-relapse mortality rather than relapse incidence. So for some reason, at least in this particular study, the non-relapse mortality was higher in this triple negatives and JAK-MPL group of patients. And one thinks that maybe these people had more advanced disease. So that's my second point. Mutational status identifies the patients who have a better outcome after transplant. And finally, is it possible to detect post-transplant relapse early with molecular studies? And here I'll show you some data which we have submitted to ASH. And this is, we recently started using this sensitive real-time PCR assay for JAK2. And let me explain how these slides go. So these 4 of these represent a patient. This is a JAK2 level at day 30 after transplant, day 100 after transplant, at 6 months, and at 1 year. With this assay, you have a patient like this over here who has very low level and would be considered negative. At day 100, you are seeing that there is a rise in level, and this patient relapses. So if you had done the conventional assay, pyrosequencing assay, these, relapse would only be detected here, whereas here we are detecting the relapse early. Here is a second patient where this yellow zone identifies early detection of relapse. And we looked at our data set, and we had material on about 30 patients who were JAK2 positive, of whom 9 relapsed. And so we went back and looked at all these patients, and it turns out that using this sensitive PCR assay, we can diagnose relapse about 144 days earlier, so almost 5 months earlier, which is very useful if you have an alternative treatment that you could use. And the alternative treatment is donor lymphocyte. This is disease that is as sensitive or even more sensitive to donor lymphocyte infusion than CML. So here is a patient who had rising JAK2 level, and there were other reasons by which the relapse was detected. And what you find is this patient gets DLI, and that at 1 year, he responds, goes into remission. This is another patient with that. This immune effect is so important in these patients that even mere stopping of tacrolimus, if these patients are on it, some of them go into remission. So here is a patient who had actually overt relapse, and we tapered him off immunosuppression and went into remission. And here is a more dramatic manifestation of that. So at 30 days and 100 days, they had disease. We stopped the tacrolimus at 100 days, and they go into remission. And this has been published also, and there are, in this particular study, 26 patients received DLI, and there was 39% CR rate, and remaining patients actually underwent a second transplant, and they could salvage totally 60% of these patients. So this is quite important. These patients, so relapse after transplant is not really, can be treated, and these patients can have positive outcome. So finally, this is my final conclusion. Post-transplant relapse can be detected early with highly sensitive PCR assay and assay for JAK2, and this identifies the candidates for DLI and immunomodulation. Thank you.